last of the online sessions, and today also we have excellent speakers. Firstly, I would like to invite Dr. Linz Paul. He is a consultant neonatologist at Mithera Hospital, Kottayam. And so Dr. Linz will be taking a very important topic, neonatal sepsis, for us. And over to you, Dr. Linz.
Thank you, Dr. Dino. At the outset, I would like to thank NNF Ernakulam and IAP Ernakulam Cochin for giving me this opportunity to make this presentation in front of this audience. And today I will be discussing on one of the most common diagnosed in neonatology, that is neonatal sepsis. So I will be dealing on these four headings, that is classification, investigation, antibiotic policy, and antibiotic stewardship. So, if someone asks me a definition for neonatal sepsis, really I can't tell a clear-cut definition. But actually, there is a beautiful definition that is given in Penrose. It is actually a syndrome in which there are clinical signs of infection, bacteremia, or culture positive from otherwise sterile set, that is blood, CSF, or urine. So, it is actually a very brief and simple definition of neonatal sepsis. So we will just classify the neonatal sepsis based on the time of presentation of the symptoms. So we will classify them as early onset and late onset. So early onset is the symptoms will present from birth till 72 hours. And if the symptoms are presenting after 72 hours, it is actually the late onset neonatal sepsis. So this early onset as well as late onset, the source of organisms and the clinical presentation and the causes are likely a little bit different. So in that early onset neonatal sepsis is mostly the maternal environment, that is the maternal genital flora, which is actually the main source of infection. Whereas in late onset, definitely maternal genital tract is an important cause. But the most important thing is the postnatal nursing environment. And coming to the presentation wise, in early onset it's mostly multi-system, whereas in late onset mostly it is a focal presentation. In early onset mostly presents as a pneumonia, whereas in late onset it's mostly presenting as meningitis. As I've already told, in the mode of transmission, definitely it is vertical, in utero or intrapartum in early onset. And coming to in late onset, it is mostly nosocomial. It is hospital acquired or rather horizontal transmission. So, as I have already told, we have divided the sepsis epidemiologically into early onset and late onset. So, we will classify the risk factors based on these two categories. We will firstly discuss on the risk factors for early onset sepsis. The most important risk factor is definitely prematurity and low birth weight. That is, any baby that is less than 37 weeks and with a birth weight of less than 2.5 kg, especially if it is a VLBW baby or ELBW baby, that is the most important risk factor for early onset neonatal sepsis. The other risk factors are clinical chorioamnionitis. There is no need for the presence of a histological chorioamnionitis. Clinical chorioamnionitis is actually an important risk factor for early onset neonatal sepsis. I won't be going to the criteria for chorioamnionitis. And the prolonged rupture of membrane, that is more than or equal to 18 hours. Some of the centers might be taking a cutoff of around 24 hours. But I think, say, more than 60% of the centers are taking a cutoff of more than or equal to 18 hours. And prolonged labor, that is more than or equal to 24 hours, and foul smelling liquor. And the next is the most important thing, multiple pervaginal examination. This, I think, even now in my hospital, the junior obstetricians, even they do a pervaginal examination many times just to see whether the head is rotated, whether it is in occipital posterior position, whether the head is in what station, -2, -10. So whenever we ask them, we are actually doing it with the sterile gloves. No. So you should, as a neonatologist or a practicing pediatrician, you should actually counsel your obstetrician not to do multiple pervaginal examinations. That is more than or equal to 3 sterile or a single unclean pervaginal examination is an important risk factor for ERNS. So also maternal fever with bacteremia before 2 weeks prior to delivery and perinatal asphyxia. That is, say, even moderate perinatal asphyxia, that is with an upper of less than or equal to 6 at 5 minutes. It is an important risk factor for early onset neonatal sepsis. So coming to the late onset sepsis, with the risk factors are entirely different. It is mostly the postnatal nursing environment which is the most important cause for allowance. If we can see, frequent invasive procedures, especially actually if you see many of the upcoming neonatologists and upcoming pediatricians might be more keen on doing procedures. So So if I ask if some of my juniors who are doing super specialization, they will tell, yeah, I have put 10 PIC lines, you have put 10 UVCs, I have done multiple intubation, Lisa. So the thing is, after you complete your learning, you should judiciously, like, which all babies you should be able to avoid these invasive procedures. That is the most important thing. And the second important thing is skin integrity, is poor skin integrity, especially in a ELBW. If it is a 25 to 26 weeker baby, the stratum corneal layers are very less. So definitely there is more chance for loss of skin integrity, especially due to temperature probe and all. So that is also a risk factor for sepsis, and repeated courses of antibiotic therapy. And I will discuss on this antibiotic therapy in detail later. And invalid vascular catheters, long-term mechanical ventilation. That is a very important risk factor. So the main thing is, nowadays in most of the, I think, neonatal ICUs, we are actually following non-invasive ventilation more than invasive ventilation. We are actually using invasive ventilation very minimally. So that is something very important. Avoid using steroids or glucocorticoids for long duration. And the last thing is the most important thing, NICU understaffing. So if you see many of the like government units, if you see, there might be 50 to 100 deliveries per day. So you can imagine the number of preterm that is coming to the neonatal ICU. So I think many of the government setup, there might be 7 to 8 preterms, and one staff might be taking care of all these babies. And there is definite chance of cross infection from one baby to other. So the NICU should be definitely staffed properly, and then we should be very keen on hand washing. So if someone asks me what is the most important strategy to prevent sepsis, first strategy is hand washing. Second strategy, again it is hand washing. Third strategy, again it is hand washing. So you should definitely reinforce the importance of hand washing in a neonatal unit. So, and the next thing is coming to the nutrition, poor nutrition. Many of the units, I think, try to keep the baby NPO for a long. So that practice should be avoided. Definitely, any preterm baby, whether it is a 24 week or 25 week, definitely at least you should start minimal enteral nutrition, and you should reasonably hike the feed in a reasonably fast manner so as to attain full feeds as early as possible. And you should avoid IV fluids or TPN for long duration and attain full feed as early as possible. So delayed initiation of enteral feedings, long period to reach full feeding, and prolonged period of time to regain birth weight. These are some of the risk factors for LONS. So also some of the anatomic defects like gastroschisis, umphalocele, obstructive uropathy, myelodysplasia. These are some of the anatomic risk factors for LONS. So for our working, or rather for our clinical purpose, we classify sepsis into 3 groups. That is suspect sepsis, probable sepsis, and definite sepsis. So suspect sepsis is when you have the symptoms or signs of infection, but your investigations as well as cultures are negative. That is suspect sepsis. And probable sepsis, you have signs and symptoms plus your investigations are positive, but your cultures from sterile sites are negative. That is probable sepsis. And definite sepsis is when you have the culture positive along with the investigations and signs and symptoms. So I think mostly we all might be dealing most of the time with this initial two, that is suspect sepsis and probable sepsis. So now the thing is, which all babies do we need to do a sepsis workup? That is something very important. So what are the parameters of a sepsis screen? I think this part we all might be familiar. The important parameters of sepsis screen are total leukocyte count, absolute neutrophil count, immature to mature neutrophil ratio, that is IT ratio, micro ESR, and CRP. So I'm coming to briefly on the component. That is, how will you say it is leukopenia or leukocytosis? So in a newborn, mostly the counts range from 5,000 to 30,000. Many times our staff, like say freshly joined NICU staff, will tell, sir, the total count is a bit elevated, like 24 or 25,000. So shall we start on antibiotic? The main thing is your leukocyte count, it will be average it will be lying between 5,000 to 30,000. So any value less than 5,000 or any value that is more than 30,000 is definitely taken as abnormal. And precisely, leukopenia is more specific for neonatal sepsis than leukocytosis. And second thing is absolute neutrophil count. So we have two charts, that is Monro and Musino charts. where we plot the absolute neutrophil, we calculate the absolute neutrophil count and plot on these charts and decide whether it is leukopenia for that baby, that gestation and that hour of life. And the second thing is IT ratio, that is immature to mature neutrophil ratio in a peripheral smear. If it is more than 0.2 in a preterm or rather 0.27 in term, it is definitely abnormal. And micro ISO, that is 15 millimeter in the first hour, and CRP, that is more than 10 milligram per liter. And something which is very important is you should definitely see on the units of a CRP. Because many of the labs might be giving in units of milligram per deciliter. So if it is in milligram per deciliter, that is 1 milligram per deciliter. And if it is in milligram per liter, it is more than 10 milligram per liter. So that is something very important. You should definitely see the units of measurement. So these are the 5 important parameters of a sepsis screen. So how will you, what is the validity of this sepsis screen? So if you ask me, the sepsis screen, the parameters have very high sensitivity and very high negative predictive value. So I think many of you might not be that like well versed in statistics. I will explain in a very simple way. So the thing is, if you have a sepsis screen which is positive, we can't say it is purely due to sepsis. But if the sepsis screen is negative, yeah, definitely you can tell it is not sepsis. That is a crux of that. That is the crux of this negative predictive value and sensitivity. So if you see the most sensitivity is for the sensitivity as well as the negative predictive value in this sepsis screen is the CRP and the IT ratio. There are many times there can be false positive and false negative values on all these sepsis screen parameters. I won't be going into the details. So if you have one sepsis screen which is positive, definitely many times our residents might be asking, sir, the baby CRP is 35. Shall we start the baby on antibiotics? No. You should at least get 2 abnormal parameters to tell it is a positive screen. So presence of 2 abnormal parameters definitely gives a very high sensitivity and specificity. Specificity is around 95, sensitivity is around 95 to 100%, specificity is around 83%, and negative predictive value is around 100%. And if the sepsis screen is negative, but you have a very high clinical suspicion that the baby is having sepsis, definitely you can repeat the screen in say around 12 to 24 hours later. And your antibiotic decision should not be delayed for that. So because you have a very strong clinical suspicion, definitely you should start the baby on antibiotic, and definitely you can repeat the sepsis screen. So as the crux is that sepsis screen is not that useful in ruling in sepsis. It is basically to rule out sepsis. Again, it is if you have a 2 sepsis screen which is positive, it can be sepsis. But if the sepsis screen is negative, definitely it is not sepsis. That is the crux. So that is about sepsis screen. Coming to the next most important parameter, that is blood culture. It is actually the gold standard for diagnosis of neonatal sepsis. And definitely it should be started in all episodes of suspect as well as probable sepsis prior to starting antibiotics. And a positive blood culture is the most specific investigation for a neonatal sepsis. And we can actually decide the choice of antibiotics also based on the blood culture report. But the major disadvantage when it comes to a neonate is that your blood culture positivity is very low in early onset as well as late onset. It is only between 20 to 30%. So we can't rely completely on your gold standard for deciding your treatment. That is something very the most important disadvantage of a blood culture. And now with the advent of backtech bottles, we can actually send very small volumes of blood culture. Previously, we should have to send say 4 to 5 ml of blood. Now with the advent of backtech bottles, with even 1 ml of blood, it is actually sufficient for the blood culture and to document sepsis in neonates. And the second thing, that is something very important. Once the blood culture is collected, it should reach the lab within 4 hours. Many times what happens is that your resident will collect the blood culture and he will go to collect the blood culture of the next baby and he will engage in some other work. and he will come in the evening and see the blood culture bottle is lying there again. So that should not happen. It should reach the lab within 4 hours of inoculation. And blood cultures should never be taken from interlink central lines. But definitely, if it is a freshly put line, you can definitely take the blood culture from a freshly placed central line. Coming to the next investigation, that is lumbar puncture. So, which all babies you should do a lumbar puncture? So, as I have already told, late onset neonatal sepsis, the most frequent presentation is meningitis. So, in any case of late onset neonatal sepsis, definitely you should do a lumbar puncture. And in early onset neonatal sepsis, there are two important indications. If the blood culture is positive, or rather if you have the clinical signs of septicemia or meningitis, definitely then you should start the baby on. Then definitely you should do lumbar puncture before starting the baby on antibiotics. And the only scenario where you should not do an lumbar puncture is that when you start the antibiotics based on a risk factor based approach. I will discuss this in later. So coming to the next important thing that is antibiotic policy. So this is something very important. Almost, I think your different units, we can't standardize the antibiotic policy for all the units throughout the world. Different units might be having different flora that is persisting. So each unit should definitely design their own antibiotic policy and antibiotic stewardship programs. So coming to the antibiotic policy. So if you are dealing with the early onset neonatal sepsis, you have two scenarios. You can start the baby on a risk factor based approach or on a clinical basis. Risk factor based approach, as we have already discussed in the previous slide about the risk factors of early onset neonatal sepsis. Suppose a baby has two or more risk factors for early onset neonatal sepsis. Definitely, I have already discussed the two or more risk factors, like say prematurity, false milling like PROM, long labor, multiple PROGen examination, asphyxia, clinical coronary. So if the baby is having two or more risk factors, definitely you should start the baby on IV antibiotics. In that is a situation where there is no need for doing a lumbar puncture because there is no clinical signs of sepsis. You are just starting the antibiotic based on a risk factor based approach. So there is no need for doing a lumbar puncture in this situation. The next thing of starting of antibiotics is when you have a very strong clinical suspicion of sepsis, like say if the baby is if the baby is in shock, if the baby is having scleroderma, then definitely you can start the baby on IV antibiotics even if the sepsis screen is negative. And any baby with at least two risk factors and a positive sepsis screen, definitely you should start the baby on IV antibiotics. So these are some of the indications in the case of early onset neonatal sepsis for antibiotics. And coming to the late onset neonatal sepsis, definitely you should start the baby on IV antibiotics on a strong clinical suspicion of sepsis, or rather you have a positive sepsis screen, or rather you have a positive blood culture. And the choice of antibiotics, we will discuss on the antibiotic stewardship in the next slide. So coming to the choice of antibiotics, as I already told, this is the antibiotic policy which is actually followed in my unit. It might be different for different units. Say in my unit, the first line is ambigenda, second line is piperacillin tazobacter, third line is meropenem amikacin, and fourth line is colistin amikacin. And we keep vancomycin, linezolid, metrozole as reserve drugs. We very, very, very rarely, or even rather, colistin also as a reserve. Colistin, vancomycin, linezolid, and metrozole. These are the reserve antibiotics we should use very judiciously in the case of neonatal sepsis. Now, the most important thing is you have started a baby on IV antibiotics and when to upgrade the antibiotics. I will give a clinical scenario which is most commonly encountered in our clinical practice. Say you have a term baby which is being delivered at 38 weeks and the baby is having respiratory distress. Your sepsis screen came as CRP which is 35 and the rest of all the sepsis parameters are negative and your resident started the baby on IV antibiotics, say ampicillin, gentamicin. And within 24 hours, the respiratory distress is not improving. And again, your since the distress is not improving, your screen was CRP was high. So you upgrade the antibiotic and after 24 hours to second line. And again, after 48 hours, your tachypnea is not improving and there is no much improvement in the tachypnea. And again, after 48 hours, you upgrade the baby to the third line, meropenem and amikacin. and by day 4, your tachypnea gets settled. So actually the clinical scenario is baby might be having a TTN, and the TTNs, it might be the normal course of the TTN to settle by day 3 or day 4. And you actually attribute to the response, and you actually attribute it to the response to the meropenem or your third line antibody, meropenem, whatever third line antibody you are using. That should not happen. So in any baby, if you are planning for upgradation, you should have two clinical scenarios where you have given a particular antibiotic for say 48 hours, and if still the baby is in shock, scleroderma, or respiratory deterioration, definitely then there is a role for upgrading IV antibiotics. And second thing is based on your fact sensitivity. Like if there is no clinical improvement and your blood culture show a particular organism, definitely at that point you can upgrade the antibiotic. So the first scenario, that is a clinical deterioration. So whenever you upgrade the antibiotic based on a clinical deterioration, definitely you should take a blood culture prior to that. But in the second scenario, you are upgrading the antibiotic based on a prior blood culture. So there is no need to take a blood culture at that point. I think that point is clear. And I will give a third scenario I have not discussed in this slide. Suppose your baby is clinically improving, and the baby is actually off oxygen, shock is everything has become passive, but your blood culture grows something which is different, whether to treat or not. So definitely the thing is that your lab parameters are and blood culture are only secondary. It is your clinical improvement, or rather the clinical decision which is more important, clinical judgment which is more important rather than your lab parameters. That is also very important. Coming to the duration of antibiotic therapy, I think might be the standardized thing which is being followed in many units. If you are starting the antibiotic based on a risk factor based approach, definitely stop the antibiotic if the blood culture is sterile. And if your culture is negative, screen negative, and a clinical sepsis, that is your suspect sepsis, definitely give the antibiotic for 5 to 7 days. And the next thing is culture negative and screen positive, that is probable sepsis. Your antibiotic duration should be around 7 to 10 days. And if your blood culture is positive without meningitis, then 14 days. And if it is meningitis, definitely 21 days. It is actually adapted from the AIMS protocol. I think most of the units might be following this antibiotic therapy. But nowadays, there are actually studies where you can shorten the duration of antibiotics, like say 7 to 14 days, even in case of a meningitis baby. I think these studies are upcoming. But since there are no standardized guidelines for that, we have to follow these guidelines for the time being. And I will go into the last part, that is antimicrobial stewardship. That is something very important. So whenever you start an antibiotic, you should be very clear regarding the dose. So many of dose, duration, as well as the route of administration. Dose, I think, say for example, you're giving antibiotic for a preterm baby with meningitis. Baby will be gaining weight by each day. And if you are not monitoring the drug dosage, you might be giving the same drug dosage on day 1 as well as day 21 of IV antibiotic. It should not happen. You should definitely revise the antibiotics based on your baby's weight. That is the dose. And also the duration of therapy. So like what happens is that many of the times you might not be clear of the duration of therapy. Even there are units that actually give IV antibiotics till the baby is on TPN or IV fluid. That should not happen. You should be very clear of your diagnosis, and you should be very clear of the duration of antibiotic and IV antibiotics. And also definitely the route of therapy. Definitely in an unit, definitely you should have to give IV. If at all you are giving IV antibiotics, you should be through the intravenous route. And in many cities, and I forgot to tell one thing. Say, for example, you have started a baby based on a clinical deterioration. You have started a baby on second line, or rather third line. Say, meropenem amikacin, you have started a baby, and your blood culture came as E. coli, which is sensitive to ampicillin. So, what will be your response? Will you downgrade the antibiotic to ampicillin, or you will continue to meropenem? The main thing is, whenever you are dealing with a sepsis, and if you have a culture positivity, you definitely always use the narrow spectrum IV antibiotics whenever possible. Definitely if the baby is sensitive to ampicillin, or rather your first line or second line, definitely you can there is possibility for definitely you can downgrade the antibiotic from third line to your second line or first line. So that is also very important. And also definitely you should be your juniors or doctors as well as your nursing staff should be very oriented regarding this IV antibiotics and antibiotic policy of the unit. So what are the essential steps? This will be the last step. About the implementation of antibiotic stewardship in your NICU. So you should be very clear on the diagnosis of neonatal septicemia, and you should be very clear of your choice of empirical antibiotic treatment. You should not. It should not be like, yeah, this baby is more sick, so you won't give ambigenda. You will give piptosomicin. This it should not be like that. If your antibiotic policy first line is ambigenda, whatever sick the baby is, you should stick on you to your antibiotic policy. Not like this baby is more sick, so you will start the baby on meropenem. This baby is less sick, you will start the baby on ambigenda. It should not be like that. And should follow your antibiotic policy very strictly. And definitely you should reassess your antimicrobial treatment as I already discussed each day. Especially you'll have to modify the drug dosage based on the weight of the baby, the gestation of the baby, etc. And in very few key scenario, we will have to monitor the antimicrobial levels also. So that is also something very important. And definitely continuous assessment and the measurement of the antimicrobial use. That is also something very important. And in your hospital, definitely there should be antimicrobial stewardship program and an antimicrobial stewardship team. So as to implement this antimicrobial stewardship policy in your unit. So this will be the last slide of my presentation. So thank you all for the patient listening. If you have any queries, you can just ask me now.
Thank you, Dr. Lins, for such a crisp and clear presentation. I think you have simplified a very complicated topic for us. One comment I would like to make, you said the blood culture, the sensitivity about 30 to 40%, I think, but the recent backtech and all, they have around 85 to 100% sensitivity.
Definitely.
What do you think? Yeah. Because whenever we send a sepsis and we think it is sepsis, we get something growing. I think the recent backtech systems, they are very sensitive. Yeah.
Yes, definitely. And also the volume also has come down. Actually, previously we used to 5 to 10, say 4 to 5 ml. Now
Yeah.
1 ml is more than.
Yeah. We have a few questions. I think we can quickly go through them. When to stop antibiotics in a suspected sepsis child is one question. Can we stop antibiotics after 48 hours in suspected sepsis? If the sepsis screen is negative and blood culture is negative, and the clinical improvement in the baby's condition.
No. Actually, if you have started the baby on antibiotics based on a clinical suspicion, if your blood culture is negative and your sepsis rate is negative, you definitely still you will have to continue the IV antibiotics for 5 days. If it is a risk factor based approach, like say you started a baby based on a risk factor based approach, definitely you can stop the IV antibiotics after 48 hours if the culture is sterile. And I think
that answers it. Is LP mandatory in suspected sepsis with negative sepsis screen?
Definitely, in a case of early onset neonatal sepsis, if you have a clinical suspicion, like say if the baby is in septic shock, if the baby is in sclerema, definitely you should do an LP before starting an antibiotics. And so even if in that scenario, if the sepsis screen is negative, you have a strong clinical suspicion, definitely you should start antibiotics after doing an LP, even if the screen is negative. If the screen is positive, definitely you should have to do an LP.
Is ciprofloxacin, is it safe in newborns?
It's actually a very contradictory thing. I think this ciproxi, this is actually a protocol that is followed in PGI. I think if ampicillin gentamicin is the reasonable choice. The main thing is the cartilage damage. I think that might be the most common doubt many of the people might be having. But I think many of the units are actually following Ciplox and amikacin in many of the units.
Yeah, Ciplox is being used widely. And last question: if the baby is in septic shock and ventilated, are you justified in starting ampicillin and gentamicin?
No, that is what I was actually telling. It is not like if your baby is more sicker, so definitely you should start the baby on meropenem. If the baby is less sicker, you should start the baby on ampicillin. Definitely you should follow your antibiotic policy. If the whatever sick the baby is, we can't tell. You can't downgrade your ampicillin to that low level. Many of the times, like say for example, if it is a listeria sepsis, ampicillin is actually the drug of choice. It's not meropenem which is the drug of choice. So, if you're like say if your unit having an antibiotic policy with a first line of say Pipso, definitely then Pipso you can start the baby on Pipso. But if your antibiotic policy is Ampigenta, definitely you should start the baby on Ampigenta first, whether the baby is ventilated or non-ventilated.
So, thank you, Dr. Lins, for answering all the questions patiently. And I think we'll go to the next talk. So the next for the next talk we have Dr. Jitin CS. He is the neonatologist at Wellcare Hospital, and Dr. Jitin will be covering neonatal screening for us. So over to you, Dr. Jitin.
Yeah. Hello, everyone. I hope you can all see my slides and hear me properly.
Yes, Jitin. Yeah.
So I would be discussing about neonatal screening. And so the contents during my session would be about the newborn metabolic screening, then the universal newborn hearing screening, then eye screening, hyperbilirubinemia screen, CCHD screen, hypothyroidism screen, and the developmental dysplasia of hip screening. So coming to newborn metabolic screening. So it initially started in the early 1960s when Dr. Robert Guthrie actually collected dried blood spots on a filter paper and diagnosed phenylketonuria. So the technique he used was bacterial inhibition assay, but the technology has later on evolved, and now we are using tandem mass spectrometry for the dried blood spots. So any screening test should fulfill the criteria put forward by Wilson and Jubner. And all the screening tests should be an ideal screening test should ideally should meet all the criteria according to Wilson and Jubner. So what is newborn metabolic screening? So it is basically testing newborn babies for serious genetic, endocrine, hematologic, and metabolic disorders before they manifest. So WHO recommendation is that all countries with the IMR less than 50 should do metabolic screening universally. So this is about I have already told about the evolution of the metabolic screen, but in future, like we can expect next generation sequencing also to be done in the dried blood spots. And with the TMS, previously, like they used to screen less than 5 diseases, but nowadays, like we can do expanded neonatal screening up to 46 to 50, sometimes up to 100 diseases we can screen using tandem mass spectrometry. So the panels that are commonly available in our country for routine newborn screening are the two disease panel, which includes congenital hypothyroidism and CAH, the 3 disease panel, which includes additional G6PD, then the 5 disease panel, which includes galactosemia and phenylketonuria also, and the 7 disease panel, which includes biotinidase deficiency and cystic fibrosis. And our NNF recommends that we should screen for 3 newborn disease conditions, which are the hypothyroidism, adrenal hyperplasia, and G6PD as the basic screening panel. And it recommends NBS under 3 groups. Group A, which should be done for all newborns, which includes the basic 3 diseases. Group B should be for screening in high-risk population, like sickle cell hemoglobinopathy, galactosemia, phenylketonuria, and Group C, it is not recommended as a universal screening in our country because of resource constraints. So when it is usually done, so the ideal screening time when we have to collect the blood DBS for metabolic screen would be 48 to 72 hours, after 48 hours. So preferably after 72 hours. So why shouldn't be cord blood? Cord blood should not be used because it takes like 3 to 6 feeds of breast milk for the metabolites to accumulate. So if cord blood is used, then some of the inborn errors of metabolism would be missed. And why should not be it later than 7 days? So if it is later than 7 days, you know that like if we send after 72 hours, the result will get after 7 days. So if we are taking the sample at 7 days, then it would even be the result will be announced even more later. So that will cause delay in diagnosis, and most severe cases of IMs will present before that. And for preterms admitted in NICU sick neonates, we usually screen at 7th day of life, and a repeat screening is done at 1 month of age, or sometimes some units will carry out at term equivalent age. That is mainly because we have seen increased 17-hydroxyprogesterone levels in preterms, particularly extreme preterms. And most of the times when we do at 40 weeks corrected age, we could see that the 17 OHP levels have come to the normal levels. And how it is done. So we usually do the sampling on a Wattman protein saver card, which contains 5 circles. And it is mandatory that the doctor who is collecting the sample should enter all the necessary details that are shown in the particular filter paper card. So how do we do? So we have to do the hand hygiene before any procedures, and we have to slightly warm the lateral aspect of the heel where we want to prick and take the sample. So we have to clean the site with alcohol, air dry for 30 seconds, and then we have to squeeze out the first drop of blood. The first drop of blood we generally don't take for testing. The next second drop of blood we will put on the center of the each circle and allow it to spread so that it is uniformly spread, and it should not overlap to the next circle. So proper due care should be given in taking the DBS samples. And once it is taken, the 5 circles are completed, we will air dry for 3 to 4 hours. And this air drying is particularly important before transporting to the NBS laboratory. So before transporting to NBS laboratory, we will put it in each individual wrappers and send on a particular day to the laboratory. So these are the common errors that can happen during the DBS collection. One could be inadequate sample collection. Maybe like some will collect only 3 circles. So why should we collect all the 5 circles? This is because for initial testing of all this condition, we need at least 3 circles, and the 2 additional circles are needed if it is required for a repunching case. So what is repunching, what is recall, I will tell later. And the other reasons why it is inadequate could be because as I told, like if the filter paper is not dried properly, then many of the wetness in the filter paper would cause the analytes to decrease, and we would get false negative report. And sometimes we would put too much of blood so that it overlaps into the other circle. Sometimes it would be contaminated with the alcohol solution. Sometimes we squeeze so much, but the blood won't come, but the serum comes. And sometimes we put on the circle 2 or 3 drops of blood. And it is called a layering, and it is also not an acceptable specimen. So certain terminologies you should know in metabolic screening. One is the repunching. So repunching usually occurs when there is like borderline results or equivocal results. So in order to clarify, we need to take a new punch from the 4th circle or the 5th circle. So it is also needed if we get an abnormal result and need a redoing of the test. What is recall? So recall generally happens if we get a highly positive or highly positive test, like very high TSH. We need to recall the patient back and get the confirmatory venous sample taken. Or sometimes there will be unsatisfactory sample, like I have already discussed. Sometimes we get a very minute. The doctor has put a minute amount of blood on the circle so that the test cannot be done. In such cases, we need to go for a recall. And where does it go? So it goes to referral NBS laboratory. We know about the regional public health laboratories as well as the state health laboratories in Trivandrum district. The other diseases which needs screening according to WHO are hearing screening, hearing, eye abnormalities, as well as for neonatal jaundice. So coming to universal newborn hearing screening, we know the risk factors for early childhood hearing loss. So many risk factors like an ICU admission more than 5 days, meningitis, then blood culture positive sepsis, family history of hearing loss, torch infection, then aminoglycoside administration more than 5 days. Those neonates are at high risk for hearing loss. And WHO recommends two screening tests for hearing, and those are autoacoustic emissions and AABR, or automated auditory brainstem response. For well baby screens, we generally adopt OAE, but for high risk cases that we have discussed, like the high risk factors, if they are present, we generally go for AABR. And how it is performed. So OEE, or autoacoustic emissions, it is performed by a small probe that is placed in the baby's ear canal, and some click sounds are delivered through the probe, and the responses from the outer hair cells are detected by the same probe. In AAPR, there would be three surface electrodes which are placed at vertex, mastoid, as well as the cheek of nape of neck, and the click sounds are delivered, and the electrodes will record the brainstem responses as waves, and there will be an inbuilt software which gives a pass or refer result. So if you tell which is better, I would go with the AABR. But AABR, because it's more resource needed, we universally screen with the OAE only. And what are the advantages of intervention before 6 months of age? So if we are detecting and intervening before 6 months, the child is expected to perform at school better, would have improved language and communication skills. So this is the 136 principle of universal newborn hearing screening. So it basically means that we should screen every baby born before 1 month of age. We should diagnose, means we have to do, if there is some abnormality in the screening test, we have to do the diagnostic test, which is ABR, auditory brainstem response, or is otherwise called a BERA, before 3 months of age. And the intervention in the form of sometimes hearing aid or cochlear implant has to be considered at least by 6 months of age. So we generally adopt a two-stage universal hearing screening. The first screen is usually done before discharge, before hospital discharge. And if we get a past result, generally we will follow up the case only. We won't go for the second screen. But if we get a refer result in 1 or 2 years, we will do a second screen, usually at second week of life. And if we get a past result, we will just follow up the baby. And if we get a refer result, we generally go for diagnostic audiology. Next is the screening about the screening for the abnormalities of the eye. So the two methods that we generally do for eye screening are external examination of the eye as well as the red reflex testing. So when should we do this screening? So before discharge from the hospital, we should do the screening. And if it is a case of home delivery, at the first point of contact with the hospital, we need to do the screening. And it should be completed within first 6 weeks of birth. And for external examination of the eye, the room should be bright, and we use a pen torch and just see the pupils, iris, and conjunctiva, as well as the eyelids. Then for red reflex examination, we need an ophthalmoscope, which should be a direct ophthalmoscope, and the baby should be in a dimly light or dark room. And the ophthalmoscope is held close to our eyes and should be at least 18 inches away from the neonate. So mostly the wider circle would cover both eyes, and we can see visualize both fundi simultaneously. Then abnormal findings are usually leukocoria, or if we find some dark spots or other silhouettes, or if there is markedly diminished reflex, those may suggest cataract, retinoblastoma, or corneal cloudiness, or maybe through the external examination, we can identify congenital nystagmus, etc. So this is generally the flowchart we use for universal screening. So if there is any abnormality with the external examination or red reflex, we generally refer the kid to an ophthalmologist. So this screening can actually be done by any healthcare personnel who is adequately trained to do a red reflex. And the screening for red reflex is usually done in a dark room at patient bedside. Then coming to the screening for newborn hyperbilirubinemia, we have three assessment techniques for jaundice. One is the visual assessment. The second is the using transcutaneous bilirubinometry or TCB. And the third one is the total serum bilirubin check. And visual assessment is not recommended by WHO for routine screening. For routine screening for hyperbilirubinemia, we use transcutaneous bilirubinometer. So what are the evidence in favor of universal screening by TCB? So it has various studies have shown that there is reduction in severe hyperbilirubinemia. There is reduction in those requiring, in the rates requiring, number of babies requiring extended transfusion. Then also readmission for jaundice is reduced with the TCB. So TCB is most reliable after 24 hours of age. So the ideal time for first screening is usually between 24 to 48 hours of life, but it is not a substitute for visual assessment. So it does not mean that you should not visually assess the baby. It means that visual assessment should be done twice a day. And if any suspicion is there, we have to do a transcutaneous bilirubinometry and a particular value, we need to go for total serum bilirubin check. And who can do the screening? So any healthcare personnel trained in using TCB can do this screening method. And the screening is usually done in the bedside or in OPD also we can do. So how it is done? So you have all seen the transcutaneous bilirubinometer. So there is a power button on the side. We have to switch it on. And once the baby is calm, we usually press it perpendicular to the skin over the sternum or the forehead. So generally, we might require 3 measurements and the machine will give a mean of the 3 measurements. And but we can obviously change according to our preference. The minimum is 2 and maximum we can go up to 5 measurements to get the mean. So this is the algorithm for screening checks. So if in case a baby is visualized to be having jaundice on day 1, as the TCB is not reliable, we generally go directly for total serum bilirubin check. However, after day 1, if we found a baby to be ecteric, we can do a TCB. So if the TCB result is within 3 milligram per deciliter of phototherapy cutoff or at threshold, or if it is more than 50 milligram per deciliter, we should go for TSP and treat accordingly. Now coming to the CCHD screen, which is actually critical congenital heart disease screen, and it is done after 24 hours of age because of high false positive cases before that time period. And the new algorithm says that we have to measure preductal saturation on the right hand and the postductal saturation in any of the lower limbs. And there is a particular criteria for pass, indeterminate result, and failed test. And only one test is nowadays done. Previously, it used to be 2 tests if it was an indeterminate result, but nowadays only one retest is done. The algorithm will be mentioned later. So if it is a failed CCHD, we can think of cardiac conditions as well as non-cardiac. We should think of cardiac conditions as well as non-cardiac conditions. So the cardiac conditions are various like cyanotic heart diseases, whereas the non-cardiac conditions also should be taken into mind, like hypothermia, sometimes neonatal sepsis, respiratory pathologies, or sometimes PPHN or hemoglobinopathies could be the cause for a failed CCHD. The evidences that are in favor for CCHD are that it decreases the infant mortality, it is very cost effective and save resources. So this is the algorithm for a CCHD screen. So we need to attach a pulse oximeter to the right hand and any of the foot. And it should be done ideally after 24 hours of age. So a pass result means that a pulse oximetry result more than or equal to 95% in both limbs. That means it should be more than 95% in both right hand as well as in any of the feet. And the difference should not be more than 3%. When it is called as failed, if the any of the limb saturation is less than 90%, it is a fail, and in such a case we need to directly go for the further investigation, which can be a consultation with a pediatric cardiologist doing an echo, or evaluate for non-cardiac conditions. When should we go for a retest? If the pulse oximetry reading is between 90 to 94%, or if the difference between the two limbs saturation is 4% or more, then we have to go for retest. So retest should be done after 1 hour of the initial measurement. In that case, it is pass if the saturation is more than 95% or the difference is less than or equal to 3%. But if it is failed in case the saturation of any of the limb comes below 95% or the difference is more than 3%. In that case, we need to directly go for further assessment. Now, coming to congenital hypothyroidism, the first newborn screening for congenital hypothyroidism was actually carried out in Vijayawada Hospital in Mumbai in 1982. They used cord blood TSH. So we follow Indian Society of Pediatric and Adolescent Endocrinology recommendation, which states that all babies should be screened for congenital hypothyroidism. Whether we should take cord blood or postnatal sample, they recommend that either is fine. So cord blood has certain advantages. One is that we need not have to prick for that TSH result. Other thing is that in units where early discharges are happening, we can actually do cord blood. And cord blood is safe for doing the TSH because the normal TSH, neonatal TSH surge happens 30 minutes after the after life. So generally the cord blood would be spared of the normal physiological neonatal TSH surge. And this TSH surge happens for 48 to 72 hours. That is why we preferably takes a thyroid screen or TSH venous sample after 72 hours. Then coming to the in-house lab testing versus central network. So basically this means like some collect TSH along with the metabolic screening that we are doing in filter paper, or otherwise sometimes we can send it to the lab that is available in the hospital where the doctor works. So either serum or filter paper screening is fine for congenital hypothyroidism screening. Now comes whether we do primary TSH or primary T4. Primary T4 approach is done only in a few states in US. We in India we generally go for a primary TSH approach, and this is more sensitive and specific for primary congenital hypothyroidism. Though they can miss cases of central hypothyroidism. So ISPAE recommendation is that we should do primary TSH assay. And now coming to the algorithm. So generally a TSH more than 20, we need to do a repeat test. So a very high TSH on the initial sample, more than 80, we need to take the confirmatory sample immediately and should start on levothyroxine. But a TSH more than 40, we have to take a confirmatory venous sample after 72 hours of age, and depending on that result, we will decide whether we need to initiate on treatment or we need not have to do. But in cases of TSH between 20 to 40, it could be due to a delayed TSH surge, and in such a case, we usually repeat the TSH after the first week. And in that case also, if the TSH comes more than 20, then we would go for the confirmatory venous sample. So in confirmatory venous sample, if we get a high TSH and a normal T4, we would repeat the TSH after 2 weeks. And in that case, after 2 weeks, the cutoff for TSH is 10. So if it is more than 10, we would start on the treatment and reassess the baby at 3 years of age. But in case if it is a low T4, like in low free T4 less than 1.1 nanogram per deciliter or low T4 less than 8 microgram per deciliter, irrespective of the TSH, or in case if it is a free T4 less than 1.17 nanogram per deciliter and a TSH more than 20, we would start on treatment. If it is a normal T4 and normal TSH on the confirmatory venous sample, we would take it as normal. Then coming to the developmental dysplasia of hip screen, we know that the DDH is very important to be diagnosed early because undetected or late diagnosed cases requires invasive surgical treatments, and sometimes they may go for staged corrective surgeries later on. And the strong risk factors for DDH are breech, female gender, and a family history of DDH. In all such cases, we need to closely follow up the baby for the hip instability. So the two tests that we are doing routinely on a clinical basis are Barlow test and Ortolani test. In both the tests, we will stand at the end of the couch facing the baby, and we should stabilize the pelvis, and we test each hip separately. And we have to hold the knee of the baby and flex the hip to 90 degrees. The index finger of our hand should rest on the greater trochanter, and the thumb should be on the inner side of the thigh near the groin crease. For Barlow test, which is actually a dislocation test, it should be performed in a very gentle maneuver because we should not try to attempt to forcefully dislocate the femoral head. And in some units, they entirely avoid the Barlow test because it is invasive. And in Barlow test, we apply a posterior force while the thigh is gently abducted. And if we feel a dislocation, then that is a positive Barlow test. Ortolani is just the opposite. We are relocating. So we abduct the hip, simultaneously applying an upward force. In such, if we perceive a palpable clump, then that is Ortolani positive. So when should a baby get DDH screen? So it should be done at time of birth before discharge from the facility, and during the routine immunization visits, we have to check for DDH. But it should be noted that Barlow test and Ortolani test we generally carry out less than 2 months or less than 3 months only. After that, we have to go for other tests like limited hip abduction test or Galeazzi sign. And because Barlow and Ortolani may be negative after these 3 months of age. And this is the algorithm generally follows. If you get a positive Ortolani, we generally directly refer the baby to orthopedics. And if we get a positive Barlow, in case like if we get a positive Barlow, we can actually wait for 1 month. Like some cases resolved by its own. But in cases where it is not resolved, we have to go for ultrasound of the hip. And if it is abnormal, we definitely need to refer the case to an orthopedician. But in case if risk factors are there, if the risk factors are there and the screen test clinical screening is negative, then also we need to carry out further clinical test to not miss a case of DDH. So the take-home messages from my session are: a screening test should meet Wilson and Chukina criteria. NBS is a program that does not end with the result of a screening test. Newborn metabolic screening is routinely done in dried blood spots. OAE is the most commonly performed hearing screen. First, a TCB screen is generally done between 24 to 48 hours of life, and DDH screen is recommended at each healthcare visits. With that, I come to a conclusion of my session. Thank you.
So, thank you, Dr. Chetan, for a comprehensive review of neonatal screening. And I think we have got two questions, if we can answer them. What is
Yes.
the cost of transcutaneous bilirubinometer?
So the transcutaneous bilirubinometer that is available in market is Drager JM105. It costs around like 5 to 6 lakhs. So the initial cost is high, but most of the settings, like within 2 to 3 years, they would make up the cost.
What are the clinical features of DDH?
So clinical features of we can perceive a palpable clunk. That is so we have to do Barlow as well as Ottolani test. And if we are feeling some instability, like it is not what we are hearing, but we are palpating. So if we suspect the Barlow test and Ottolani test to be positive, it is ideal that we should refer the case to an orthopedician for expert opinion.
So thank you, Dr. Jitan, once again.
Thank you, sir.
So next we have the last session for our essential newborn care online session, that is thermoregulation in newborn by Dr. Johnny, neonatologist at Medical Trust Hospital, will be taking over the session. Over to you, sir, for the next session. Dr. Johnny. So Dr. Johnny will be taking this.
Yeah, okay. Thank you very much, Dr. Jidin and IAP for giving me the opportunity. Can I share the screen now?
Yeah, please share, sir.
Okay. All right. Yeah. So I think you can see my my screen.
Yes. Visible.
Okay.
Clearly visible.
Yeah, so mine will be the last one of this session of online teaching, and I will be seeing you on Sunday for the offline practical session. So basically, my topic is neonatal thermoregulation, and just 1 second. Okay. So, okay. So basically, we need to do what is called thermal protection. This is any measures that you do to ensure the baby is maintaining normal body temperature, which is 36.5 to 37.5 from birth onwards. So the babies needs to maintain their normal temperature between 36.5 to 37.5 degrees centigrade from birth onwards by giving the environment which is suitable to maintain this one. By providing this appropriate and stable thermal environment, it is important for newborns, regardless of their size or gestational age, to prevent hypothermia as well as hypothermia, because both of this will make the baby to produce spend a lot of energy which can be used otherwise for growth. So if you are hypothermic, child will need to produce more heat. More energy will be utilized for producing the heat. So we all know there are mainly four mechanism of heat loss. So one is evaporation, where we lose heat during evaporation of fluid from the body's skin surface, especially when the baby is born immediately after birth. Due to evaporation of amniotic fluid from the body, baby can lose weight, lose heat. So this can be, as we know, can be prevented by drying the baby as soon as the baby is born with a warm cloth, and then immediately removing that with a fresh, dry, warm cloth. Radiation is when the heat is lost to cooler objects in the environment. Like and these objects are not really touching the baby. Like you have a cold wall or windows which are close by the close to the baby. It can lose heat by radiation. And the next one is conduction, whereby baby lose heat from being in contact with a cold surface. Say, for example, cold mattress or cold weighing machine, things like that, which you can actually prevent by keeping the baby on a warm surface, and then use warm mattresses and all that. And the other one is convection. Convection is when the baby loses heat due to the air moving around the baby. So when the baby, when there is lots of air currents around the baby, then baby can lose weight, heat. So now coming to the so these are some of the, how babies lose heat. One is radiation that we already discussed, cold room temperature, cold walls. So these things we need to be careful to prevent baby losing the heat. Conduction, cold scale, cold X-ray plate, cold blanket. Convection, bed near air vent, oxygen left on. So you need to warm the oxygen, and air traffic, air draft. Evaporation, wet diaper, bath, and tachypnea. These are a condition where you will lose the heat. So why newborns are at risk of heat loss and hypothermia? Because babies have got high body surface area relative to the body weight. So up to 3 times that of an adult. So even the babies are small, their body surface area is relatively high. Secondly, they got thin epidermis with increased evaporative losses and decreased subcutaneous fat. This causes easy loss of heat loss, and also the immature response to cold stress. And babies depend on non-shivering thermogenesis as a primary mechanism, like brown fat. Those are things which will actually generate heat in the babies, unlike adults who shivers to improve the heat. So all these factors are more pronounced and more with the decreasing gestation. So more preterm babies have got more of this problem. Okay. Okay, I'll switch on the video. I don't know. Video is no problem. Okay. So who are at risk for developing hypothermia? So as I said, preterm babies, especially those with a birth weight of less than 1,500 grams, small for gestational age. In case of hypoxemia, acute illness, abdominal wall neural tubule defect, like you have omphalocele, those sort of things can actually cause lots of heat loss. And infants with the persistent and unexplained hypothermia should be also evaluated for hypothyroidism. So, what is the usual physiological response to cold stress in infants? Basically, cold stress causes norepinephrine release in the babies. And this norepinephrine, as we know, causes peripheral vasoconstriction, which reduces conductive and convective heat loss, thermogenesis via brown adipose tissue. So this causes non-shivering thermogenesis. And norepinephrine also stimulates the release of thyroid hormone, which is T4, which gets converted into T3, that actually upregulates expression of uncoupling protein 1 in the mitochondria. So basically, this will lead to reduction in the ATP synthesis and oxidation of free fatty acid. This causes heat production. So there is what is called thermoneutral zone. So every baby is this a range of environmental temperature where a newborn can maintain normal body temperature with minimal metabolism. So the whole idea of maintaining this thermoneutral environment or thermoneutral zone is that baby doesn't need to spend extra energy or calorie to maintain the temperature. So minimal metabolic effort and less oxygen consumption. So usually the smaller the baby, the higher the ambient temperature required to maintain the body temperature. Slightly higher in the initial 1 to 10 days, then the required temperature becomes less. So what are the signs and symptoms of hypothermia in babies? So as we know, obviously body may be cool to touch, and then baby may have mottling, or may look pale. There may be central cyanosis or peripheral cyanosis. Baby have problem with the feeding and hyperperfusion via skin. And baby may be hypotonic and irritable. And symptoms may be signs may be bradycardia, tachypnea, shallow or irregular respiration, including grunting, apnea, lethargy, and metabolic acidosis and hypoglycemia. Because this hypoglycemia is because child spent energy for producing fever. I mean that to improve the temperature of the baby. So how do you manage hypothermic neonate? So newborn with the symptoms or signs of hypothermia you have to measure the axillary temperature. So digital thermometer is better, and we don't generally recommend mercury thermometer anymore. I mean, we don't use the mercury thermometer anymore because of the hazards, but mostly we use digital thermometer. The important thing is the thermometer should also be able to identify temperature from 30 degrees centigrade onwards. Because otherwise you might take it, sometimes you may not identify hypothermia. Most of the thermometer actually identify hyperthermia rather than hypothermia. So this you need to be careful. And if the temperature is just 36 to 36.4, this is where the baby will have cold stress. So baby can be treated by covering the neonate with warm clothes, remove cold or wet clothes, and warm the environment, including room and bed. So you maybe turn off the air conditioner, or maybe keep the temperature of the room to something like 25 to 26 degrees centigrade, and ensure skin to skin contact with the mother, and then continue breastfeed. So this is like cold stress. So baby he is technically or potentially can develop further deterioration of the temperature, can develop moderate hypothermia. So if it's a moderate hypothermia where the temperature is between 32 to 35.9 degrees centigrade, you provide extra heat by room heater, applying warm towel, or using phase changing mattresses. And baby can also be rewarmed in an incubator or radiant warmer if available. Maintain skin to skin contact with the mother if possible, and use warm room or bed. Take measures to reduce heat loss. If the temperature is less than 32 degrees centigrade, it's like severe hypothermia. You are likely to be in serious trouble. So those babies definitely will need to be admitted in ICU, and will need rapid rewarming using radiant warmer or incubator until baby's temperature is 34 degrees centigrade. So until 34 degrees centigrade, you can do rapid rewarming, maybe in an incubator or under radiant warmer. But then afterwards, you have to rewarm the baby slowly to 36.5 degrees centigrade, which is a normal one. Take all measures to reduce the heat loss. The 4 types of heat loss I was talking about, uh, radiation and convection, conduction, and all those things. And you may need to start the patient on IV fluid to maintain the blood sugar in the normal range. And probably patient may also need oxygen, vitamin K. If it's not already given, you do a vitamin K or repeat a vitamin K. And if the patient is not improving, like the previous speaker said, you may need to consider the possibility of sepsis. And in all cases, monitor the axillary temperature every half an hour to 1 hour till it reaches the normal temperature of 36.5. Then you have to continue monitoring these babies hourly for the next 4 hours, 2 hourly for the next 12 hours. So this is the most important chart in terms of how you manage a hypothermic neonate. There are various devices you can use for thermal support. So less than 32 weeks, we have various incubator. More than 32 weeks can be uh, managed under radiant warmers, open care, like that. And so incubators basically reduce the insensible water loss and convective losses. Double wall better for irradiative losses. So you have a single wall and double wall incubators available now. So if you keep the modes in air, keep the temperature at thermoneutral environment, and depending upon the age and weight of the patient, or otherwise you can keep the patient on servo mode, skin temperature between 36.5 to 36.8. Early phase, you may need to give humidification 80% for less than 28 weeks for the initial 7 days, after which you gradually wean the humidification. There is also risk of sepsis with the humidification, but modern incubators are more safe in that aspect. Excuse me. Radiant warmers can be used for more than 32 weeks, but however, they got risk of increased water loss, insensible water loss, and servo preferred the skin temperature 36.5 to 36.8. Manual for during resuscitation, you have to use manual mode. And also always try to keep the room temperature 25 degrees and cover the bassinet with the polythene for small neonate. And the hybrid, there are now various hybrid incubators and heated water-filled mattresses and some phase-changing materials that can be used for maintaining the temperature. So how to prevent the heat loss? So this is the so-called warm chain. So there are 10 steps for warm chain from the time the baby was born. So step one, when the baby is born, you take care of the thermal care in the delivery room. So you keep the temperature 25 to 28 degree in the room. You either turn off the air conditioner or you make the temperature 25 to 28 degree. Make sure there are no draft, airflow in the room, and pre-warm the radiant warmer and linen. So use a pre-warmed radiant warmer and linen. During resuscitation, make sure you use all warm supplies, equipments, drugs, and all those things, including fluids, oxygen. And make sure you dry the baby immediately to avoid evaporative heat loss. You dry with a warm towel, warm dry towel, and start with the head and then cover with another warm dry towel, and also use cap to cover the head. So baby loses also temperature through the head. Then make sure you do skin to skin contact with the mother. This improves, in fact, stability, blood glucose, and improves breastfeeding. And start breastfeeding within 1 hour, and then postpone the bathing or weighing till the baby is discharged. And then make sure you use 1 to 2 layer cap, socks, mittens, and mother and units kept together. And then even when you want to transport, either you use mother and baby skin to skin contact as for stable transport. Otherwise, you use incubator for very low birth weight babies. Check the temperature before and after. And training and awareness is very important for healthcare persons. So basic principle is warm chain at every stage from birth, transport, and onwards. So so two clinical scenarios. One is a 28-week preterm delivered in a district hospital. The temperature is 35 degrees centigrade at 30 minutes of arriving to the main hospital. So what went wrong? So basically, as I said earlier, probably you may not have kept the room temperature, and it's a 28 weeker. You actually receive the baby in plastic, food gradient plastic cover, and then without drying the baby, and then you keep the baby directly under the radiant heater. And the baby could have kangaroo care, but 28 weeks is a good size stable baby. You can actually do kangaroo care, and then transport the baby in a warm incubator, etc. see, for example, another one is in a term SGA baby transport and ICU arrives cold, hypoglycemic and lethargic. Again, these steps, if you are careful, you can avoid being hypothermic. Now, the next question is, how do you do the neonatal temperature recording and how often do you do? So, usually you do accelerate temperature, which is the safest thing to do. As I mentioned earlier, use digital thermometer and avoid mercury. And especially make sure you have low reading thermometers, like up to 30 degrees centigrade. And we also have thermistor probe now available, which is attached to the upper abdomen in warmer and incubator or warmer or incubator. You can actually feel the baby, feel the abdomen and the hands with the back of your hand. And if the baby's hands and feet are warm, abdomen is also warm, maybe baby is in a thermal comfort. But if the baby has a cold hands and feet and warm abdomen, baby is in cold stress, that's the time when you need to consider warming up the baby, removing the wet linen and all those things. And if the baby is all cold, baby is in real hypothermia. Baby is in a danger. We may need to admit the baby and then may need to do the rewarming. So, how often do you check the temperature? One is immediately after the initial care. On arrival into the nursery or postnatal ward, healthy neonate with mothers check if its feet is cold. If the sick neonate, you check the temperature every 1 to 2 hours, and as the child gets weight is less, then you do more often. So, what are the various temperature ranges that we mentioned earlier also already? Normal temperature 36.5 to 37.5 degrees centigrade. Uh, when the patient's excuse me. Patient's temperature is between 36 to 36.4. Child is not hypothermic, but is at risk. So baby will need intervention immediately. Wrap skin to skin contact, warm room, and all those things. Moderate hypothermia is when your temperature is 32 to 35.9 degrees centigrade. This child is at risk for complication and requires urgent rewarming and monitoring. And when the temperature is less than 32 degree, it's a medical emergency and child need risk of cardiorespiratory instability and metabolic issues, and maybe baby will need admission and urgent medical treatment. But never forget that hypothermia is also a problem with the baby. Sometimes you do excess warming, or sometimes dehydration or environmental overheating can also cause hyperthermia. That's temperature more than 37 degrees centigrade. But at this point, also the point is infection can also cause hyperthermia in children. So if that's the case, we need to do screening for the babies, infection screening for the babies. So these are the various modes of care, different gestational age and postnatal age. Less than 28 weeker, you can do plastic bag. You can receive the baby in the plastic bag, and then warm humidified gas can be used. Others, if it's more than 32 to 35 weeks, you can actually do skin to skin contact, skin to skin care, and also radiant warmer care. And as the child gets better, most of them can be looked after by skin to skin care or heated mattress or radiant warmer. So, in preterm neonate, you need extra measures, as I mentioned earlier. Polythene occlusive wraps and thermal mattresses, as per the NRP guidelines, and receive the baby in food grade polythene bag or wrap without drying. Place on radiant warmer. Do not bath the preterm babies for the first few days. Increase the ambient humidity up to 80% incubated for the first week, and then gradually wean off 5%. Monitor temperature more frequently for the preterm babies. So as I mentioned earlier, hyperthermia is also a problem more than 37.5 degrees centigrade. You look for the causes, including sepsis, and the child may be irritable, apathy, in severe cases dehydrated and shock. So it can even lead to death. So treatment is normal environment, undress, frequent feeds, tepid sponge if more than 39 degrees centigrade, and evaluate the cause. And key takeaway here is prioritize warm chain, thermoneutral environment, and pretest physicaro to prevent dysregulation. So just few words about therapeutic hypothermia or induced hypothermia. Now it has become standard of care for hypoxic ischemic insult, intentional controlled hypothermia, and it can reduce neuronal loss and subsequent brain injury. So therapeutic hypothermia is now a standard of care for such patients. It is a time-sensitive therapy and needs to be instituted within the first 6 hours after birth to be more effective. So, protocol, history of acute perinatal event, non-reassuring fetal heart racing, cord prolapse, placental abruption, pH less than 7, base deficit more than or equal to 16 on cord gas, or gas obtained within 1 hour of life. 10-minute sub-gas score less than or equal to 5, and baby is requiring assisted ventilation initiated at birth and continued for at least 10 minutes. And so the target temperature during this period up to 72 hours will be 32.5 degree to 34.5 degree. And core temperature should be monitored every 15 minutes. Sometimes you can have hazards of temperature control methods. Sometimes if you are not careful with the servo control warmer, you can get hyperthermia. And the other problem is undetected infection because the servo control temperature may mask the hypothermia or hyperthermia unless you specifically look for it and then do the screening for sepsis. And can also have volume depletion, especially you keep the baby under radiant warmers. So the key takeaways from this is neonates, especially preterms, cannot control their own temperature well. Hypothermia and hyperthermia are dangerous but preventable. Thermoregulation must be a team priority. Warm change saves lives. Always check temperature. Act promptly when it is not normal. And a warm baby is a safe baby. Thank you very much for patient listening. And I can take any questions if there are. Otherwise, thank you for the time. Dr. Gino.
Yeah, thank you, sir, for the very practically oriented presentation. And I think there are no questions here. So I think warm thank you to all the participants who have stayed with us throughout and to all the faculty. So good night to all. So we'll call it a day. Thank you all.
Okay, thank you very much. Thank you. Bye-bye. Good night.
Good night.